So good evening everyone. Today's discussion is on diabetic TRD, the surgical indications and the surgical techniques, and the session is moderated by Dr. JSR sir. So diabetic retinopathy, as we all know, is a leading cause of potentially irreversible blindness, and TRD represents an end stage of the diabetic retinopathy. The first human pars plana vitrectomy was performed by Robert McKimmer in 1970. It was on a diabetic patient with a non-resolving vitreous hemorrhage. Since then, many advancements have taken place in the field of vitreoretinal surgery. So with higher cut rates which are available now, vitreous can be efficiently removed without causing much traction on the retina. There is a lower incidence of breaks and bleeding. And with the introduction of anti-VEGF, there is a reduction in the intra-op and also the post-op bleeding. So there has been an increase in the indications for the VR surgery in proliferative diabetic retinopathy. So these are the indications, as we can see: non-clearing vitreous hemorrhage, traction lateral detachment, combined retinal detachment, an epiretinal membrane, vitreomacular traction, and neovascular glaucoma. So today's discussion will concentrate on the tractional retinal detachment. Coming to the pathophysiology of tractional retinal detachment. So the pathophysiology of tractional retinal detachment, as we know in diabetes, there are many growth factors including VEGF, which favor angiogenesis, due to which the neovascular buds they form, and they use hyaloid as a scaffold, they invade the cortical vitreous. Firm adhesions are formed as a result between the hyaloid and the inner retina, and there is also a co-development of contractile fibrous tissue, which causes anteroposterior as well as tangential traction. So excessive traction on the retina can cause it to deform and attach. We call it as a tractional retinal detachment. And the new vessels, which are fragile, can also bleed, causing a vitreous hemorrhage or a subhyaloid hemorrhage. So there are many classifications that have been proposed for TRD, but there is no consensus regarding the accepted classification. It is typically divided into macula involving, macula threatening, or an extramacular or non-macula involving TRD. So what are the indications for vitrectomy in TRD? So TRD involving the macula, or an extramacular TRD with a documented progression towards the macula, which we call it as threatening the macula, which we can document on an OCT, or TRD behind a vitreous hemorrhage, which precludes the evaluation of the macula. So coming to the pre-op evaluation of the patient, well, the pre-op visual acuity is important, as the post-operatively the visual gain by the patient depends on it. And good anterior segment evaluation is to be done to look for neovascularization of the iris, of the angle, pupillary dilatation, and the grading of the cataract, whether we need to perform a combined cataract surgery along with the vitrectomy or not. A good dilated examination with binocular indirect ophthalmoscope gives us the idea about the media clarity, the extent of the TRD, and also the disc and the macula status. We should know about the status of the fellow eye. If there is a very bad TRD and the fellow eye of the patient is good, then we can give an option to the patient to observe the bad eye. And also the general health condition of the patient should be known. The kidney status, requires dialysis or not, whether heart diseases like is he on any antiplatelet therapy that we need to stop in accordance with the cardiologist. And also good counseling should be done regarding the possible outcomes, complications, and the guarded visual prognosis post-surgery. So what are the investigations that we'd like to do? Ultrasound is useful in cases of dense vitreous hemorrhage where there is no view of the fundus. It also helps us to know about the areas of traction and also the topography of the detachment, and to assess the areas of PVD, where the PVD has occurred in which quadrant. So as we can see in this, in the left image, there is an X pattern TRD which indicates a focal traction and a small area of associated detachment, whereas in this picture there is a H-shaped pattern. We can see there is a broad vitreolateral adhesion and extended detachment, also called as a tabletop detachment. OCT is required to assess the involvement of the fovea, whether the fovea is involved or is it threatened. This OCT shows that the fovea is attached, but there is detachment temporal to the fovea. And this OCT is showing that fovea is detached. So do we need to give a preoperative anti-VEGF? So many studies have been done to know about the role of anti-VEGF. It reduces the intraoperative bleeding time and the surgical time, and induces the regression of new vessels and reduces the vascularity, so which helps in easier dissection, which further reduces the surgical time. So what will be the indications for a pre-op anti-VEGF? The patient has extensive fibrovascular proliferation, flat neovascular proliferations, if the patient has neovascularization of the iris or the angles. So the presence of more fibrous than a neovascular component is a risk factor for aggravation of a TRD. So in those cases, we may choose to defer anti-VEGF and proceed directly with vitrectomy. So the timing of anti-VEGF. So various studies have been done to investigate the appropriate timing and the effects of the anti-VEGF agents. This review was done, which included studies in which the anti-VEGF was given from a period of 1 day pre-op till 14 days pre-op. And they found out that the surgical time, incidence of intra bleeding, iatrogenic breaks, silicone oil tamponade, and the frequency of diathermy, they were significantly less in the anti-VEGF pre-treated group than the non-treated group. This meta-analysis, it included 26 studies. There were 5 groups which were analyzed. First group, in pre-op more than 14 days before surgery, anti-VEGF was given. And anti-VEGF was given. Next was 6 to 14 days, 1 to 5 days at the end of vitrectomy and a sham injection. So they concluded that the pre-op treatment at 6 to 14 days showed the best efficacy in improving the post-op BCVA, reduced the duration of the surgery, incidence of recurrent VH, and also the intra-op bleeding. This study was done in which the patients were divided into 2 groups. The first group received anti-VEGF only pre-operatively, and the other group received both pre-operatively and at the end of the vitrectomy. So the pre-op, the operative duration and the occurrence of intra-op hemorrhage, retinal breaks, and silicone oil tamponade, they found to be similar in both the groups. However, the combination they found that it reduced the incidence of the post-operative vitreous cavity hemorrhage. So they gave the explanation that pre-operatively, which is anti-VEGF which is injected, gets washed out during the vitrectomy, and also there is a post-operative surge in VEGF levels due to the surgically induced trauma and the inflammation, so which is responsible for the post-op vit cavity heme. So anti-VEGF can also cause crunch syndrome, which is the progression of TRD after an anti-VEGF injection. It can cause a sudden loss of vision between 1 to 6 weeks. The mean onset in the study was found to be 13 days. The mechanism is that there is an angiofibrotic switch. Following the anti-VEGF injection, the VEGF levels decrease, whereas the other factors like connective tissue growth factors, they remain constant. So which leads to a pro-fibrotic environment. It can lead to a increase in the traction. So it is preferable to have surgery within 3 to 10 days of injection. So it is therefore important that the surgical fitness of the patient should be obtained before we give an anti-VEGF injection. But if the patient is not fit for surgery, we can offer a preoperatively PRP, can be considered in treatment advice if the media clarity allows. Should be done from at a safe distance from the base of the fibrous membrane. It also helps in the induction of PVD and better ease of surgery and reduces the time needed to complete the intra-op endolaser. But surgery should be done at least 2 weeks after the completion of a PRP because the retinal edema should be reduced. Otherwise, the iatrogenic breaks will be more during the surgery. So what are the goals of surgery in a tractional retinal detachment? So we have to clear the media, remove the vitreous scaffold, relieve the traction over the macula, both the anterior-posterior as well as the tangential traction, remove the surface fibrovascular proliferations, and also then the photocoagulation of the ischemic retina and the retinal breaks. So coming on to the surgical techniques, if it is a non-dilating pupil, iris hooks can be used or any other pupil dilating medium can be used. If there is hyphema, it is suggestive of NVI or NVA. It can be cleared by making paracentesis. If it is recurrent, we can inject a viscoelastic into the AC to prevent recurrent hemorrhage. If cataract is there, combined cataract and vitrectomy needs to be planned. So what gauge will we use? It's usually a surgeon's preference. The larger gauge instruments, they are stiffer instruments and they provide a higher flow rates. So the surgical time is less, but the smaller gauge PA provides a lesser post-operative pain and better rehabilitation of the patient. Study was done, a hybrid approach was used. Smaller gauge instruments were used through the larger sclerotomies. This 27 gauge cutter was used through the 23 gauge trocars. So the benefit of smaller gauge is that it can fit, the cutter can itself go under the membrane, can be used as a forceps for dissection and cutting mode to remove the membrane. The hybrid approach, however, will add to the cost of the surgery. So the number and location of sclerotomies, usually 3 sclerotomies as we make in any other vitrectomy, 3.5 to 4 mm from the limbus depending on the lens status. So additional is to be used if a bimanual surgery is planned. And the location can be variable. Mostly we can use the inferotemporal because there is most space is there in the inferotemporal quadrant. So first step will be the relief of the anterior-posterior traction. In first step is the anterior vitrectomy and the core vitrectomy. In case of dense VH, we should clear the sclerotomy site first, and once we get the view, the anterior vitreous should be cleared. Without the biome, we also can clear. It prevents the lens damage and helps to clear the organized blood behind the lens capsule. So we should first create a clear anterior vitreous before putting on the biome. Next step is creation of a posterior hyalodotomy. So during the mid-vitrectomy, we can see if there is a highly mobile gel. So we prefer that site for making a posterior hyalodotomy. If there is a restricted movement of the gel, which indicates there is a wide attachment of the posterior cortical gel. So in this case, preoperatively done ultrasound is helpful in knowing in which quadrant there is more space between the retina and the posterior hyaloid, and we can proceed with the hyalodotomy in that quadrant. After making a hyalodotomy, we clear the subhyaloid hemorrhage. Subhyaloid hemorrhage should be clear till there is visualization of the retinal blood vessels. So, and as we clear it, as more fluid gains access into the subhyaloid space, there is a circumferential opening of the posterior hyaloid, which we call as a truncation of the cone. So this video shows there is a large fibrovascular proliferation with dense subhyaloid hemorrhage. In this, after the core vitrectomy, a hole is made in the posterior hyaloid, as you will see. So there, now we have engaged the hyaloid and we have created an opening there, and the subhyaloid heme beneath it can be removed. This can be extended circumferentially 360 degrees to relieve the anteroposterior traction. This is another video showing similar creation of a posterior hyalodotomy and removal of the subhyaloid hemorrhage. So next, coming to PVD. Why is PVD different in diabetic vitrectomies? Because usually it is incomplete, with there are multiple pinpoint attachments which are mostly confined to the posterior pole. And there is also vitreoschisis, which is the splitting of the posterior vitreous gel into multiple layers. It contributes to the double layer of the second membrane, which we call of the tangential traction. It can lead to residual vitreous if it is not identified during the surgery, which can reproliferate in the postoperative period and lead to recurrent attachments. Next step is the relief of the tangential traction. It is the
Why do you want to do truncation of cone before going to the membranes?
So that the whole anterior-posterior traction is removed, and when we are cutting the membranes, there is no transmitted traction to the anteriorly. We can have a peripheral break during the membrane. So coming to relief of the tangential traction, it is a key step in diabetic vitrectomies. It is difficult because mostly in diabetics there is a thin ischemic retina. It can cause variable amount of bleeding and also iatrogenic retinal damage. So coming on to segmentation. Segmentation is a step in which a large sheet of fibrous tissue is cut into several smaller islands. Forceps, scissors or vitrector can be employed for segmentation. The goal is to separate the vitreous into islands of small fibrovascular adhesions which have minimal traction on the neighboring retina. So first, a core vitrectomy is performed. As we can see in this image, the anterior-posterior traction is relieved. After the anterior-posterior traction has been relieved, the posterior vitreous surface, it is cut into various small islands. As we can see here, there are various small islands of fibrovascular tissue which is remaining. So what are the disadvantages this will have? As we'll be cutting through the membrane, we'll be cutting through the blood vessels, so it will cause more bleeding. And also residual tissue, it can reproliferate in the postoperative period. It can cause a recurrent detachment. This is a pictorial representation of segmentation. A large sheet is cut into smaller islands, and the smaller islands, they are managed individually. So this is a video showing a combination of segmentation with subsequent delamination of the fibrovascular tissue. So after delamination, minimal or no residual tissue should be there on the surface of the retina. In this also, this large sheet is segmented into smaller islands, and each smaller one is managed individually with the cutter. Coming on to delamination. In this also, similar steps are to be followed. First, the anterior-posterior traction is removed by doing the core vitrectomy, and then the sheet of fibrous tissue, it is removed by removing the fibrovascular nails or the pegs one by one. The advantage is that it will cause a lesser bleeding, as we will not be cutting through the vessels, and more complete removal of the fibrous tissue as compared to segmentation. In this, the edge of the fibrovascular prolif is lifted, and the adhesions between the retina and the fibrovascular prolif are cut. The dissection, it could begin either from periphery to center or from disc side, that is inside out, or a combination of both depending on the availability of the cleavage and the height of the TRD. So this video, it shows a unimanual technique of dissection using a curved scissor. This shows the scissor, it is parallel to the retina as compared to segmentation, where the scissor will be perpendicular to the retina. So we go in between the retina and the membrane. We lift the membrane and identify where the epicenter is, and we gently remove it with the scissors. Using both blunt and sharp dissection, the epiretinal tissue is removed from the underlying retina, and then the cutter can be used to remove the membrane. So the advantage, as we can see, that there is minimal bleeding and no residual fibrous tissue on the membrane, on the retina. Sorry. So there are various techniques which have been described for delamination. One by one we'll see. So this is a fold back delamination. It is useful in removing flexible or weakly fixed membranes. We put the cutter just behind the membrane, behind the membrane's leading edge, and with high cutting and aspiration, the membrane is folded back into the port. Next is a conformal cutter delamination. In this, the thickened membranes are there. It involves dissecting the thickened membrane directly by moving the cutter port into the leading edge of the membrane. We have to adjust the cutter away from the retina so as to avoid the risk of retina entering the port. Another technique is lift and cut. In this, the cutter is applied to the edge of the ARM. The cutter is used as a pick or a forceps, and the membrane is lifted. And once it is lifted, and then we cut the membrane with the cutter. Another technique is lawnmower technique. In this technique, the membrane is first lifted using the cutter or a forceps, and then the whole of the membrane is then shaved using the cutter. First the membrane is dissected, and then the lifted edge can be directly trimmed with the cutter. So en bloc dissection, it was described by Abrams in 1987. This was the type. So in this, what we do, the anterior-posterior traction is not relieved completely. Here the anterior-posterior traction, it is kept intact from three sides. Only from one side it is removed, and from the other three sides it is used as a third instrument, and the membrane is delaminated in an outside in fashion. So, but the disadvantage will be that there is an increased risk of iatrogenic peripheral breaks, which will be caused by traction at the vitreous base, because the anterior posterior traction has not been relieved. So coming on to bimanual dissection, it is helpful that because we can hold a forceps in one hand and scissors or cutter in the other hand for the separation. This gives us a better control. In a combination of sharp and blunt dissection can be used to remove the fibrovascular breaks. One by one we can remove it, and it gives a better control over the membrane, which causes lesser bleeding and subsequently lesser surgical time. It's just that we'll have to make an additional sclerotomy port for the chandelier. So this video is showing that inferiorly a chandelier port is placed, and then bimanual surgery is carrying on using forceps and scissors. So the location of the chandelier can be decided based on the location of the configuration of the RD and where we want to dissect. Like if we want to dissect superiorly, we'll prefer to place it chandelier superiorly, because if we place it inferiorly, the membrane can cast a shadow and the dissection can be difficult. However, it varies from surgeon to surgeon. So where do we initiate the dissection? Periphery to center or from center to periphery? Depends on the RD's configuration, the surgeon's preference, and the available instrumentation. So what are some of the other techniques? Like viscodissection has been described by Hubbard. It involves there is an instrument, consists of an extendable probe with a lumen which is connected to the VFC, which we use for silicone oil injection. The flow is controlled via the foot pedal. So the cannula which is there, This the tip of cannula is an opening is made in the posterior hyaloid, and the tip of the cannula is oriented parallel to the retina between the membrane and the retina, and controlled injection of viscoelastic along with the blunt dissection using the cannula itself is carried out to delaminate the hyaloid and the fibrovascular membrane away from the retina. Another technique described is proportional reflex hydrodissection. The port of the cutter, similar to the viscodissection, it is placed between the tissue and the fibrovascular tissue and the normal retina. And with the foot pedal, surgeon has the control over the fluid which comes out in a proportional fashion to create a separation between the fibrous tissue and the normal retina. So once a separation is created, the cutter can be used to dissect the fibrovascular membranes away from the retina tissue. So can we leave a little bit of proliferative tissue behind? Although it is preferable to remove thoroughly, completely to ensure attachment, but this should be balanced with the potential risk of iatrogenic retinal breaks. So it is beneficial to leave some residual tissue if they are not causing any associated with any peripheral retinal breaks, or they are not causing any anterior posterior traction. So hemostasis, it is equally important. We should stop the dissection as soon as the membrane bleeds, and we should avoid large clot formation, as it can be very difficult to remove a large clot because it can also get adherent to the retina, and we have to do the surgery again as a membrane only. It can be achieved by increasing the infusion pressure, cauterizing the bleeder, can be done with the mechanical pressure using the cutter itself. And if all is not working, we should pay attention to the patient's BP. We should ask the anesthetist colleague if we can reduce the patient's blood pressure. So after the membrane removal, remaining fibrovascular stalks, they may be treated with diathermy to prevent active bleeding. So this video is showing the use of diathermy to control the bleeding. Superficial light cautery burns should be applied, preventing iatrogenic damage to the retina. So next step is the peripheral vitrectomy. So the clotted blood in the vitreous base should be removed, as it can cause postoperative vitreous cavity heme. Scleral indentation helps, especially in phakic patients, to do a more complete vitrectomy. Coming on to photocoagulation, we should, after the surgery is over, we should examine the periphery for any breaks. Any break which has happened should be marked before fluid gas exchange followed by endolaser. And we should try to complete the maximum PRP possible intraoperatively. It can be performed in a typewriter fashion or anterior to posterior, but the typewriter fashion tends to be easier as the distance between the probe and the retina remains similar, constant. So areas chronic traction may not take effective laser uptake during intraoperatively. If retinal breaks are there or a combined RD is present, endolaser should be placed after FGE. Retina is reopposed to the RP under air. If there are no breaks, the subretinal fluid may persist, and further laser can be added postoperatively as the retina reattaches. So what is the choice of tamponade? Air can be used if there are no breaks and short-term tamponade is needed, but oil or gas is preferred in complicated cases where break is there. Oil is preferred in cases with large multiple breaks, which can be pre-existing or iatrogenic, and in those with residual traction. So what are the advantages of oil? Well, like we can do a fill-in laser pre or post-operatively also. Leads to a faster visual rehabilitation. So one-eyed patient, we should prefer oil instead of gas. And there is no limitation of air travel. So what can be the disadvantages? There will be sub-oil hemorrhage, glaucoma, and the subsequent need for another surgery to remove the oil. So what can be the complications of vitrectomy in TRDs? Intraoperatively, we can have bleeding, as we saw how to maintain the hemostasis. Iatrogenic retinal damage can occur, corneal edema. Postoperatively, we can have recurrent vitreous hemorrhage, recurrent retinal detachment, cataract formation, IOP fluctuations, and neovascular glaucoma. So how to avoid iatrogenic retinal damage? A good debulking of the peripheral vitreous is important before proceeding for the membrane surgery. We should use a higher magnification for membrane surgery so that we know which tissue we are cutting, and also controlled movement should be done. But what if a break is formed, iatrogenic break forms? We should mark it with cautery. Cautery helps in two ways. A bleeder can be there at the edge of the break, so it will help to control the bleeding also. And also after FG, it will be easier to identify the break. And if a break is there, it needs complete traction relief. We should continue the dissection away from the break and work our way towards the break instead of going from the break, as it will lead to elongation of the break. So recurrent vitreous cavity heme. It is seen in 7 to 63% of the patient, almost half we are seen on the first post-operative day. Cause can be secondary to incomplete intraop hemostasis or persistent bleed from the dissected fibrovascular tissue. So how to prevent a recurrent vit heme? Intraop thorough removal of the residual vitreous should be done. IOP may be lowered to check for any ooze, and if there is any ooze, we can do a cautery to that area. And a good intraop PRP helps to reduce the chances of recurrent vit cavity heme. So this was a study done here for UBM of sclerotomy sites we had seen after pars plana vitrectomy for vitreous hemorrhage. This found a significant association between the occurrence of rebleeding and fibrovascular proliferation at the sclerotomy site at 6 to 8 weeks. So if there is a recurrent vit cavity heme, UBM helps to make a management decision, as the fibrovascular proliferation, if it is present at the sclerotomy site, will need a surgical intervention. So fibrovascular proliferation can be seen as a high reflective stock of echos, which are originating at the sclerotomy sites and with radiations in all directions. Is there any role of encerclage in TRDs? Well, it can be in cases with extensive retinal detachments or combined RDs extended up to the periphery, or with extensive fibrovascular proliferations, or if there is a peripheral FVP with an unrelieved traction, which we cannot relieve without sacrificing the lens if we want to preserve the lens. So what are the poor prognosticating factors before taking up a patient for the chronic and advanced disease at presentation? If the macula has been detached for more than 6 months, the height and the duration of macular detachment, if there is ischemic macular optic neuropathy, macular thinning and ischemia, outer retinal or photoreceptor damage on OCT, and also systemic factors like BP, sugar, and the renal parameters. So take-home message will be that diabetic vitrectomy is not an easy procedure. The PVD is difficult. So there are multiple vascular truncation points, which can cause traction points are there, which can cause bleeding. So often what we see as a focal fibrovascular tissue, it can be connected to the retinal surface by a big entire sheet of membrane. So hemostasis is key, and all the various techniques are described. So generally what we use is a combination of all the techniques, and keys to successful membrane surgery lies in the correct identification of the posterior hyaloid and the plane of dissection.